This is for Dr. Ramakrishnan. Can you think of the bispecific or trispecific as a platform that can be applied elsewhere, and is multiple myeloma the first time this platform is being applied?
Can you hear me? Yeah. So no, I think multiple myeloma was not the first time. Probably the first example I think is blinatumomab for leukemia. And I think this platform can be applied to any malignancy, really, where you have targets. So the target is really what's important. So you want a target that's just on the cancer cell. You don't want it on any other cell, right? If you can identify that target, again, the technology is at a point where this is like putting Lego blocks together. You just put your different pieces together and you can make one really, really easily. But that specificity is the challenge, and not every cancer is going to have that. But bispecifics are being looked at in breast cancer, lung cancer. We have some approvals in that space, prostate cancer. So I see it as a huge class of agents that's going to be available for multiple cancers.
I'll say one thing about, I'll make a plug for UT. So at UT, there's something called the Protein Therapeutics Core. It's run out of the Department of Chemical Engineering, and it's run by someone named Jennifer Maynard, and they can produce bispecifics from really any antibody that's available, so they're engineering those. And then the other is that this is an area where aspects of AI have come in, and so if you have a molecule, there are now ways of, so there was a Nobel Prize awarded a year ago for how proteins fold and are designed, and so now people are incorporating that into designing these molecules. And so it may be that, the idea in the end is that if somebody has a specific abnormal protein, you should be able to computationally figure out what binds to it, build that antibody very quickly, and then really personalize treatment. So that's one of the goals sort of down the road.
We didn't make much mention of it here, but there's actually more than also T-cell products, which might be of fascination to you all. So in general, when we talk about these antibody immunotherapies, there's kind of three levels to them. One is what we call the naked or conventional antibody, which is just a single antibody that targets some target on a myeloma cell, in this case, or any cancer cell. Then we have antibody drug conjugates, where you've tied to an antibody a payload or nuclear warhead. We have one in the myeloma space, which is belantamab mafodotin. Mafodotin is tied to the belantamab space. And then the third category is the largest one, which is multispecific antibodies. That's then split into T-cell antibodies and then actually NK cell antibodies. The NK products are also an investigation. And then underneath that, under the multispecific heading, we have the bispecifics, the trispecifics, and then the theoretical tetraspecifics. So as the NK product cells also come along, it could be a very fascinating space. You could have one cell target one antigen and then cross over to its analogous product doing something else.
Question on this side. This is for anybody, how do you anticipate that AI will help accelerate research or even a cure for myeloma?
Hello, it's working now, okay. So I think there's multiple different avenues for AI. At the scientific level, these antibodies, drugs in general, simulations, we have something called, I think HealthTree does this too, but myeloma twins, not just real people, but you can actually simulate some of these things. There's a lot of data that's already been going through. I don't think we're quite there yet, but I'm really excited to see how you can do clinical trials without actually putting patients on, and being able to extrapolate. So all these trials we talk about for myeloma, because yes, people know about it now, but it's still a rare disease relative to all other diseases out there and other cancers even. So most of our trials have 90 to 120 patients and the therapy gets approved, right? And why that real world data right now is so important is because most of my patients weren't patients that would have been on that trial. So when I give these treatments, especially at the beginning, I have no idea what's going to happen. And people have rare toxicity to all different things. So I think using AI to help with some of that would be really, really exciting. And then something that's happened in my family recently, you know, I'm hoping AI can just help with the day-to-day stuff right now. So medicine is fantastic, but 50,000 errors happen that are, you know, related to just some random documentation or something like that. And I really want AI to help with that right now, today. So if someone's allergic to something, but my Epic had it and yours didn't, right, and we give the drug, I mean, there's so many places in healthcare, I think, that AI could really help us do much better for all our patients.
Okay, next question. Kind of following up on earlier question regarding what's kind of a diagnosis for or determination for relapse. Already through 4 lines of therapy, CAR T would be next. We've talked earlier, got Dr. Rama, my transplant doctor up there, talk about when and where, and we're talking, not where, but talking about how you want your T cell stills to be strong. You want a lower burden of myeloma. But you also want to wait as things keep getting better and stronger and not, you know, you want good bridging therapy, already on the therapy that would be considered bridging therapy. Where is that line for when you pull the plug and say, okay, we've done that balancing act enough, and we should move forward with the next line with that CAR T for anybody?
So I guess one way to approach it would be is, you know, I think that part of it is where it's going too far, right? So you definitely don't want to get to the point where now you can't go back or you can't go on to the therapy that you've planned next. So I think that's an important one. I think that just about every therapy that we have has some toxicity. And so there are cases in which you use, let's say, something that impacts the immune system, someone gets an infection, and then they can't go on to the next therapy. So I think it's really like trying to balance it's all a balancing act. You definitely want to get down the disease burden for many therapies, but at the same time, you don't want to push it too far. So I think a part of it is that, you know, if somebody has, like, for example, recurrent infections, you know that they're probably going to get another infection, right? So what can you do to try to prevent that? Maybe you take them earlier versus not. But I think that really knowing kind of how people have responded before, what kind of problems they've run into. I think people with, let's say, renal disease are different than people without renal disease. Other things, if people have a history of cardiac problems or not. So I think it's really taking all of that into account. But you definitely, I think, want to set goals with the person before and say, look, we're going to try to get you here and we're going to try to get you to this point. Sometimes it's really timing. And it may be that it takes X amount of time to get to a therapy, like you order the therapy and it's got to be made, or you order the therapy and it's got to go through your insurance and then it's got to be made. So there's a built-in time. And you might say, look, we just want to get through the time and then go on. But I think that we are, I think it's really like, you don't say, well, let's do this. We'll go ahead and we'll see you back in 6 months. It's like, we'll do this and we got to monitor you along the way if we're anticipating something else coming. So it's different for everyone, but you want to look ahead and just, if you want to get to a specific therapy, everything you can do to get there, but you definitely got to get there, right?
Thank you. I have 2 questions, if that's okay. The first one, I think someone had said something about only 20% of patients have access to CAR T in the US. Did I misunderstand that?
No, I said that one. So out of all the patients who are eligible for CAR T, 20% actually get CAR T. It's the same with transplant. And it's partly because you have to be associated with a place that can do CAR T, and then be willing to come and stay there, right? So there's a lot of reasons why that's the case, but yes, that is the latest statistics that we have.
So basically have to be sort of a patient already in that facility that's offering CAR T, and then maybe then...
You can come to other facilities for sure, that all of us do it, but your doctor, or your doctor has to know about it, right? To then refer you, and sometimes that's the issue, that in the community, most of our doctors have to take care of patients with so many different cancers, and if they have 5 or 6 myeloma patients, you're not going to know all these things at the top of your head, right? And so that's why this type of program's so good, because you can educate yourself and then say, I want to go to one of these centers. But that's one of the reasons that patients just can't get in. There's insurance issues sometimes and things that there's other reasons as well, but the knowing part is one of the bigger ones too.
Okay, and Medicare or private insurance, that would make any difference, or does it?
So Medicare covers, and private insurances cover. If it's Medicaid, there's only certain centers that will do it, because these are really expensive therapies. So insurance does unfortunately play a role.
Okay, and Dr. Patel, also this one is for you. I thought I understood you to say something like taking out the cells, like do the CAR T, you do the bridge, you do the CAR T cell induced, and then some.
Yeah, I
like
talked
you
it
take
out.
the cells
I
out.
was yeah, sorry. I'm jet lagged, so I went in a different direction. So before you make the CAR Ts, you have to take them out first. So you actually do the apheresis as the first part, and then they get sent off.
Got it.
So that's the taking out, not afterwards.
Okay, thank you for clarifying. Thank you.
And just to clarify, CAR T is not like an age-related thing. Kind of like, I think sometimes people think it's stem cell transplant is kind of very similar to if you
Exactly.
can or can't get CAR T. So do you just all want to speak to that?
Sure. So in general, with stem cell transplant, where we have a much more of an age bracket, classically the age was 70, and now CMS won't pay for someone above the age of 80. That's kind of been the cap. We don't think of that the same way with CAR T therapy, that there's no theoretical upper age limit. We actually think that it's gentler than stem cell transplant, and so we really try to keep the doors open to patients, and we just try to think of someone's fitness to go through it all in general, and that's very much individual.
Yeah, and I'll put in a plug here where we have different CARs, right? I didn't talk about the differences. One seems to be much more efficacious than the other one. The other one's still really good. The toxicity is also a little higher with the other one than the other CAR T ide-cel. So a lot of our older patients, or our patients on dialysis, or our patients that have severe other comorbidities, we actually do ide-cel for, and they can do really, really well. Again, when you give better bridging, there's less myeloma, which is not what the studies did. Patients can do really well. There are studies looking at bispecifics versus ide-cel that are going to come out. Again, I think everybody should get all of these therapies if they can. So there are certain patients, I would say, that are not ineligible for CAR T. Apparently, there's another conference going on somewhere that someone quoted. They asked who's eligible, and they quoted that, well, if you talk to Karina Patel, everyone's eligible. One of my lymphoma colleagues just texted me that. So, yeah, for the most part, but patients who have dementia, for instance, or have significant comorbidities that keep them from being able to walk how they need to, or do their own self-care, that's where if you have any major side effect, it's going to worsen your quality of life. So those are my patients that I would say probably not the right thing to do. But again, anyone else, even if you have a little bit of a comorbidity or something that we can modify, then we do it. And we pick different CAR Ts based on that toxicity profile.
And I'll just put a little plug in for clinical trials here. We've all talked about how they're very selective, but as people are aging, they're also fitter, and they may have comorbidities, but they're often clinical trials that might be the best option for them. So there are dual CAR Ts that are rapid manufactured that potentially have less toxicity profiles. The CAR Ts that we're driving right now are the first generation, right? So it's like the Ford Model T. It's got to get better. And so we want a Tesla. That's what I drive. I don't know if I should say that, or how people feel about that, but it's a good car, and it's very sophisticated. So that's kind of what we want, a really nice designer car. And there are plenty of clinical trials at all of our institutions, and I would definitely ask your doctors about those options, because those are often good options.
I very much appreciate the analogy of CAR T therapy to cars. Could not be more beautiful.
And to me, this is why you need to see a myeloma specialist. If only 20% of eligible patients are getting CAR T-cell therapy, it means 80% of the patients are actually getting treated in the community, and they're not referring to these physicians. So you need to tell your friends.
I have a very patient-specific kind of question, and some of us have kind of been bouncing around this before. And it kind of centers on the timing of therapy and things like that. And I understand each person's different, and it's between the patient and the doctor to make the decisions. But one of the things I've noticed, so I'd been on therapy, and now I'm completely off therapy for a while, and watching things slowly grow, and wondering when the next therapy is on my horizon. But there are studies we've seen where you have statistics. If you have MGUS or smoldering myeloma, you should be able to kind of expect this kind of percent each year kind of thing. And one of my doctors says, oh, well, you have MGUS, right now. And I keep saying, well, but I had myeloma, so I'm not the same as the MGUS person who hasn't had myeloma. So I'm like secondary MGUS instead of the primary MGUS. Are you aware of any kind of study that kind of suggests for patients who have had the disease and are now in some sort of remission, an MGUS or a smoldering-like remission, what the statistics tend to point towards for the next progression, or for the next, when you're going to have it, when other patients tend to have the next therapy or anything like that?
I can take that, and then whoever wants to add. So there is actually an entity called secondary MGUS, like a true secondary MGUS. This is because we have patients who have had transplant a long time ago, that a new clone popped up that was completely different from their original M protein or light chain. So it really seems like it's biologically a different clone. That's like an MGUS. And so this has happened after CAR T for a few of my patients as well, that it's a different clone. They had IgG myeloma, IgG kappa, and now they have IgM lambda that came out of nowhere. And we see it go up, and then we see it come down without doing anything. And you're like, this is weird. It's just the immune system being weird. That's a little different than what I think you're saying. So patients, there are 10% of our patients after transplant, their myeloma never really comes back. So, we talk about cure. There's probably some patients we cured with transplant itself, especially back in the day. Has to do with age too, in my opinion. So if someone is older and they get 10 years out of transplant, but they die from heart disease or something else, we said they were cured, but if they live long enough, maybe that myeloma was gonna come back, right? So this is where the definitions are a little bit, you have to put it in context. But I do have quite a few patients who had standard risk myeloma that did really well on maintenance for a long time, 4 or 5 years on maintenance. They're MRD negative. We stop their maintenance, and they're on observation. They're another 5 years out, really doing well without their myeloma, and it's just slowly coming up. And so eventually, I think I'm gonna have to treat most of those patients, that it's gonna start causing some issues, but it's just very indolent. It's almost like something called follicular lymphoma. In lymphoma, we have aggressive lymphoma, and then we have indolent lymphomas. In myeloma, we see that too. And so, you happen to have an indolent, which is great. But the problem is we can't ever say that it's never going to come back, and we can't tell you 100% when it's going to come back. For the engineers in the room, right, they always come with their graphs of their M proteins and their light chains that are coming up, and a lot of times they're correct. Like, they can actually calculate when it's going to hit that 1 or when it's going to hit the 100 for the light chain. And again, that's the biochemical relapse. And then you talk to your doctor, like, hey, I'm doing really well. My MRI or my PET scan's negative. My bone marrow doesn't really show a lot of disease. Can we keep watching? As long as you're still getting those testing done to make sure you don't end up with issues with your organs, I do. I talk to my patients. We decide to do that. But again, that's it's a personal choice versus, hey, when I'm biochemical progressing and I'm at that highest level of M protein of 1, most patients likely are going to have problems. So we say you probably should get treated by that time.
So there haven't been, I think the question of if you are in a remission and the disease, you can see it coming back, as Karina said, and really the patient is doing fine, you're doing fine, but you now see the M protein come back or the light chains become abnormal. It used to be, as Arvin was saying, we didn't have very many drugs, and so each drug was kind of like a book of tickets at Disneyland way back when they had that. So every time you used a drug, that was a ticket that was taken, and then your book of tickets was empty, and then you had nothing left. So we tended to be more conservative and wait until people actually ran back into problems, like they developed anemia, they developed renal failure, and then you say, well, now it's time to pull something out. So with sort of many more drugs, the question is, should we treat people earlier and right as the disease is coming back, or should we wait until they actually get symptomatic? So that's something where there's never been a study that's really specifically looked at that question, but people have looked at this within the context of other clinical trials, and it does seem like if you treat people earlier, you might prevent some of those from running into problems, and so you're helping them down the road. Here again, I think that it is really like a balance of, in some way, let's say after a transplant, you're kind of resetting the clock, and so if you think that all myelomas come from MGUS, right, and it takes X number of years to get there, it may take X number of years to come back. And so I think a lot of it is really, we can't predict that from the beginning. So it's really time that allows us to sort of sort that out. And so I was talking to the group earlier today about time here is your friend, right? So just because you see something, you rarely have to do something right then and there. So you can see someone in a couple of weeks or 3 or 4 weeks and say, look, how are things changed? And if things are exactly the same and they're sort of puttering along, that's different than if things are shooting back up. So I think you can use, myeloma is a disease where it has an aggressive nature, but it is stretched out oftentimes, even especially in early stages over time. So you use time as your friend to make good decisions, right? And I think that that's time patients could use to now learn about, think about, and kind of talk to people about what might be the next step when and if you need to get there, but let time help you. Like there's almost nothing we have to deal with in myeloma where it's rare that it's like, okay, you have this, put you in the hospital, we have to treat you tomorrow. Like that is a rare occasion. So you have time to sort of map it out.
Hello. For someone who's high risk, like myself, I'm stage 3. Went through, excuse me, bone marrow transplant, very early relapse, 2 months in, already moving towards CAR-T therapy. In a case like this, given this history, should I, going through CAR-T, should I push for maintenance to begin immediately considering the previous very early relapse, or would you recommend awaiting that a positive response? And a follow-up to that, just any suggestions for effective drugs or recommendations for maintenance therapy post CAR-T?
Yeah, this comes up a lot. So as of right now, most of the studies and the way it's been approved is without maintenance, right, as a one and done. And I think that's really important for the majority of patients, that the one and done is such a big deal. Again, to say that someone's functionally cured and not on treatment, that's the only way you can do it, right? However, having said that, we do have some of our really high-risk patients that I worry about. The study I showed you, that even some of our high-risk patients can do really well without any maintenance. So right now at MD Anderson, we don't give maintenance to anybody. What we do is if someone has an active myeloma plasmacytoma somewhere after CAR-T, we'll do radiation. So we do consolidation radiation. That seems to have helped. There are centers that will give pomalidomide, for instance, for anybody that still has any kind of myeloma left, or if they were high risk, they'll use that as a maintenance. There are clinical trials that are looking at this. There's been a couple clinical trials that closed that were trying to use cell mods as a maintenance, or even trying to use a bispecific. Some of those were logistical reasons as to why they closed, because the bispecific didn't exist anymore. Others were because the cytopenias after CAR T were so high in late-line patients that if you try to add anything at that point, the white count's so low, the platelets are so low, it just added a lot more toxicity than actually helping anything. We couldn't give it, right? In early line, those are the studies that are going to be they're being done now, so hopefully we'll have more data. So unless someone has really aggressive disease, as a standard of care, it's not a known that we do it. But again, I don't have any data to say which one's the best to do. The easiest seem to be IMiDs because at least they're oral. But again, it's going to be based on your counts and all those. And when do you start? We don't know. Because you might get a really good response anyway, because I've had patients who have relapsed early, and they're over a year out from early line CAR T still in a remission. So we just don't have enough data, I think, to say that to everybody. But if someone wants to be more aggressive, the main thing is most patients with CAR T, they're going to be MRD undetectable in that first 1 to 3 months. If you're not MRD undetectable, if there's still a clone, that's usually what's going to grow out because there's no other therapy that's on, right? The problem with M proteins, and light chains go down fast, but the problem with M proteins is it can take a long time to go down. So you might not get to 0 for 6 months to a year. So when we talk about response, you can't use the M protein. But if you're MRD undetectable, your PET scan's negative, that's a really good response, and we know that that M protein down the road is going to get to 0. But if you're not MRD negative, or we see a PET scan that looks like there's something active, we talked about this earlier, that you either biopsy it to see if it's still myeloma, because again, when you go to a one and done, there's no more pressure on any of those cells. So if anything's active, it's likely going to grow. So that's the other way that they can look at MRD, and if you're positive or the PET scan shows something, you biopsy it's positive, then we know we need to do something after that CAR T.
And I think one other way to think about it is that, high-risk disease is high risk because it doesn't respond to the treatments that are typically given, right? And so at some point, if we, when Arvin and I were growing up, we used melphalan and prednisone, right? And so once you came and did something like started using a proteasome inhibitor, now like high-risk disease for melphalan and prednisone was now sort of negated. It was like everything else. And so one thing to remember about a CAR T is an immunotherapy. So all chemotherapies kind of work the same way, and the way they work is that they stress out the cells. So like if you use melphalan or something like that, it messes up the DNA, and the cell decides that it can't take that, and it kills itself. So that's how many therapies work. Immunotherapies work differently. So immunotherapy the T cell comes up to the thing and actively kills it. So it's not relying upon the tumor cell to say, look, should I live or die? So that's why things that might be high risk when you're doing non-immunotherapy, those things may not matter as much when you're giving immunotherapy, right? Because it's a different way of killing. And so this is why risk sort of changes over time, because as we introduce more therapies, right now, what is bad for after a autologous stem cell transplant may be completely negated if we gave people immunotherapy. So I think it remains to be seen. But those two things are very, very, very different in the way they act. And I think that really the risk that we see now is primarily based upon all of the chemotherapy that we use, not immunotherapy.
In general, just I'll add one thing, that with CAR T therapy, even from its inception, going back to Carl Jr. University of Pennsylvania, in some ways it was kind of constructed to become its own maintenance therapy, if you will, that the CD3 positive T cell cascade lives on, and so there's ongoing activity, and that's believed to be part of the benefit. So maintenance therapy beyond that has not been well established because you don't want to damage part of that CD3 positive cell cascade. So to give something aggressive after that, you could harm what the CAR T therapy itself did. So this is why it's very much been an active question and controversy in the field.
Hello. I guess first of all, thank you all for an excellent roundtable. So you guys done a great job explaining things in a good way. So CAR T seems to be the best game in town right now. And we have to do a collection. And I think I understood that it's best when our myeloma is low and we're in good shape to do that collection. Can we just collect now if we're in that kind of good condition and just freeze it? Would that be a strategy that could help? And then when the time comes for CAR T, you thaw them out and you do your engineering and you re-inject them.
Okay, I think I got the question. Okay, sorry, I only heard part of it at the beginning. So the question is, can we just get our CAR Ts early and then use it down the road when we need it? So do the collection. Right. So that's been a huge question we've brought up. So what if we collect T cells when people are collecting their stem cells, right? Or at the beginning, because we know those T cells are going to be the youngest and the least amount of treatment it's seen. The biggest issue with that is where do we store it and how do we use it? So most of the CAR Ts that are being made today, these are from fresh cells. So you have to collect it, you have to make the CARs right away. Once you make the CARs, there's an expiration date. And so that expiration date is usually 9 months to a year. And we can't estimate when the right time to give those CAR Ts are, and no one will pay for collection and storage of T cells either. So if I went to your insurance to say, okay, they're first line, but I just want to collect these cells, they won't let us because it's not approved in that indication. Now people are working on that, saying, hey, can we use frozen cells to actually make these CAR Ts so that maybe we can eventually find a way to just collect them early and freeze them. There's a lot of logistical and scientific data that still needs to go into that to say, are these just as good? Because again, anything we do to those T cells changes them, and we want those younger, healthier ones, right? We don't want the exhausted ones. So there's still, it's not completely, some places are trying to do it, but it's not quite there yet. So as of today, we don't collect early. The only time we've collected cells and not given right away is from our patients who needed bridging therapy. So when we collect, you can have myeloma. We're not worried about myeloma coming into your CAR T product like we do with stem cell, because this is a different, we're doing something different here, right? This is not the chemo that's gonna kill your myeloma, this is the T cells are killing your myeloma. So if you have a lot of myeloma, I can still collect, as long as those T cells are there, we can still collect and make them. But during the bridging, if my patients only got a little bit of response, or I think that there's another therapy that can work. I've had a patient get 6 months of bridging to really knock down their myeloma first because it was just slowly going down, and then we gave the cell 6 months later. But again, it's because there was a reason we were doing that.
And I'll just add here, the other question, I think what you're trying to hit is, can we get these T cells to be the best T cells, right? And there's another approach to this, which is use T cells from somebody else. Just use a young kid, 18-year-old kid who's in the prime of his life, and get his T cells to do the job. The issue around that is, how do we make sure that your body doesn't reject that? And there are studies looking at that now. Also, the logistics of all of this. Right now you have to suck T cells out. It takes a while to manufacture. If it's off the shelf and ready to go, there are advantages to that, right? You don't have to wait for the manufacturing component. So this is a very evolving space. And the other thing Dr. Patel showed you at the end is the in vivo stuff, right? What if you get something like a COVID vaccine and it turns into a CAR T in your body, which sounds like science fiction, but that kind of technology is coming. So it's really exciting, and in my world right now, insurance really dictates everything. So that's a challenge, and I'll be honest that's probably the main barrier why we can't do a lot of the stuff you're talking about. Like, no one's going to pay for it, right? So that's a major issue.
And one of the other things that's emerging is using something called induced pluripotent stem cells. So they can take a cell, a skin cell, make it back into sort of a very primitive state, and then try to coax that into becoming other immune cells. So you sort of go backwards and then you go forwards. And so there are some early products, that are using the, so you take some cell from you, it doesn't have to be a T cell, you make it into a stem cell, they engineer that to be a CAR, and then they grow them up and then they give them to you. So that may be one approach later on, where like as you're making these new cells, they're now fresh because you're making them from a stem cell. There's a million things that need to be figured out before that become standardized, but that is also something I think holds promise down the road.
Thank you. Any idea about using hyperbaric oxygen therapy and drinking South Korean red onion juice?
So hyperbaric chamber therapy and other kind of alternative therapies.
So I talk about this with my patients a lot, and I joke because I'm Indian. People ask about turmeric all the time. There's still myeloma in India too, I promise. So I think supportive therapies are really important, right? But I think the issue is we don't have a lot of data on safety and if it works at all. So for instance, high-dose vitamin C will make your Velcade not work, right? You go through the liver and it actually flushes out the chemo, so then the chemo doesn't work. So that's one we already know of because a lot of people were trying to take high-dose vitamin C and someone tested it. I think with hyperbaric oxygen, I get a lot of these questions. We don't know. We know it works for wound healing, so that's one place that I have used it, but for everything else, I don't know if it's gonna actually cause problems. So one thing I think about is, can it increase your risk of clots, right? I don't know, but just theoretically, clinically thinking, what else can it do? And I don't think there's any data that tells us that this actually helps in terms of myeloma. You know, when we talk about tumors in general, there's actually mechanisms that are, the cancer learns how to live in different area. Again, there's so much out there that I have no idea if it actually helps or hurts. So I tell my patients not to do anything without talking to their doctors, and especially spending a lot of money on things, right? That's the other issue. With some of the other supportive therapies, you said the teas, again, a lot of these teas have other ingredients in there that could actually affect your liver or kidneys. And then we end up seeing people with major, toxicity to the other treatments we're trying to use. So I would just be really careful. I usually have my PharmDs look through when they have time, the different ingredients of those and tell me if there's anything that could have, harm them, and we go from there. We do have an integrative group that's looking at some of this too at MD Anderson. We've had trials we've done actually with things like turmeric and high dose other things, and nothing's panned out to say that it is helping. And the problem is that a lot of these supportive therapies, you don't know what's in there. So even when we tried to get turmeric, each bottle had something different. Each pill had a different amount, like when you actually, do the mass spec to see what's in there. So it's really hard to tell you that it's okay to do those.
Hi. Quick question. Post stem cell transplant, is there a length of time for maintenance therapy? Revlimid and maybe Velcade. I'm status post 3 years, and this is something my oncologist and I are discussing.
Well, I think there's some evolution on this. I remember a time where we did none, then time where we did a couple of years, then it was forever. And then I think now there's also people coming in complaining, well, I can't do this, So you have to talk to your doctor about where your disease is. I think if you have good risk disease and you're MRD negative after a couple of years, how much more is it buying, especially if you're having toxicities? There's a little bit more discussion of that and a little bit more data out there. But, generally, if it's not bothering folks, I try to have them on some therapy indefinitely. But, definitely in the last couple of years, had more conversations and have taken some folks off therapy because they were just not tolerating it, and the degree of benefit was unclear.
Right, and especially you have to remember that, compared to, let's say you get diagnosed with myeloma, you start on therapy, like you can see the numbers change, right? If you're in a remission, you can't see whether anything is changing. Like hopefully things like minimal residual disease might help us. And the issue is really like, if you're MRD negative for 2 years, is it safe to go off of your main, like those are questions that are super important questions, but they take a long time to answer. And so those studies are ongoing now, so I think we'll get better at tailoring maintenance. But I agree with Arvin is that, look, if at some point the juice is not worth the squeeze, right? And so it's all a balance of how much is it affecting you. Like there are people, like we've all had patients who've been on Revlimid for decades and they are like, it doesn't affect them. We have other people where we've whittled down the dose over time. So I think that it's for you, I think it depends, but we've all had patients, I think, who have said, look, I'm done. I'll still come and see you, but I just don't want this anymore. And that is totally fine.
Okay, we'll do 2 more questions.
This is just a general question. So for the T-card therapies, are there any viral or fungal infections that like completely prohibit? I mean, I know that most of those things can be target, but because you lower the immune system first, right? Are you addressing those viral or fungal infections at that time, depending kind of, because of course when the immune system goes down, right, that can possibly pop up. And is that, I guess the second part of the question is, since you target certain, I guess, checkpoint of this T cell, right, with T-card, does the viral or fungal impact it, or is it like usually separate from multiple myeloma where it doesn't cross over, I guess?
So those are fantastic questions. So yes, I do have patients who have had some serious viral or fungal infections. Fungal infections are rare in our patients, at least earlier line, but I've had some patients. You absolutely have to have those treated before you collect the T cells. One, because you don't want it to come into the product when you give it back, when you've immunocompromised someone after the CAR T infusion. But 2, when you get CAR T, you're at a huge risk of some of those infections happening again or reactivating if there is still something left. So what I do for any of those patients, we make sure, like CMV, I've had a lot of patients with CMV that we treat. We make sure it's negative, that they're off and they're only on maintenance therapy. And then after CAR T, our infectious disease doctors actually monitor them with me. And sometimes we'll put them on prophylaxis for CMV just to really help keep them from getting it, depending how bad that infection was. Same thing with fungal. Everybody, even without a history of any infections, will go on some kind of prophylaxis during the time of the CAR T, but we stop it because after counts come up, we're fine. But maybe for patients like this, we will leave it on for a little bit longer to really make sure that those infections don't happen. Great question about the T cell health when you're having those chronic infections, because we know that those T cells are being used to go after those. I don't have studies to quote, but yes, ideally, I would like to collect your cells when we know those infections have been gone for a while, right? But it doesn't mean that we can't make them. So I have had patients where we're able to take those T cells and still make a CAR, and they still worked. There's just not enough data for us to individually look at those T cells to see if they're ready or not.
Hi. Thank y'all again so much, and thank you, HealthTree, so much for coming to Texas. Thank you. It just means the world to all of us. Sorry. Lately, it seems like the issue of blood clots has been coming back up. I happen to be somebody who also has AFib. In addition, I did Revlimid, now I'm on Pomalyst. So I'm kind of like paying attention, because I'm on Eliquis twice a day, 5 milligrams. But again, it does seem like the blood clot issue I've heard it more on Zooms lately. And I'm wondering, do you think it's because people are living longer because now they're getting treatment that we didn't have available, so they were dying before, their hearts or whatever were put under that much, or their vessels were put under that much stress, or what? I mean, so maybe do all patients need to readdress this issue with their doctors? I don't know.
Sure, happy to chime in on that one. So for one, the blood clot issue has been well known for a long time with immunomodulatory drugs. And I'll back up just a little bit. As we've actually even studied MGUS more, there's an increased signal with MGUS for blood clots. That is statistically significant, small and not clinically meaningful, but it's statistically significant, meaning there's suggestion of some connection there. And this is even outside of some people, what you might have heard of MGTS. Even outside of that known clinical syndrome, which you haven't heard about, don't worry about it. But even with just standard MGUS, there is a small incidence of increased blood clots. So we have known that with than MGUS. We have certainly known it for myeloma. There are actually even blood clot calculators for multiple myeloma specifically. That's outside of one that's more conventionally used for other cancers called the Harana score. So that's with the disease of myeloma. Then on top of that, the immunomodulatory drug adds kind of another hit to it, where that it increases the risk of blood clots overall. And so classically, we've used aspirin. Aspirin actually does have great efficacy, and that's what we have typically used. But for some people who have an additional risk factor, such as atrial fibrillation, or a previous history of a blood clot, or for some other reason you think they might be more prone, that's where a newer agent, one of the DOACs, such as Eliquis, Xarelto, comes in. And that works quite well. But you actually were very insightful in your question in that when we look at the incidence over time of blood clots, we have seen it march along higher, and it actually is believed that it is related to age. That if you just think about a population without any issue at all, if you follow them long enough, you will see a signal for all kinds of diseases, but amongst them clots. So in general, the immunomodulatory drugs have had a lot of use in the frontline setting, in the maintenance setting, and so we have seen more of those clots by virtue of their increased use alone. It is not clear that there is actually anything else biological behind it. Doesn't mean that there isn't. We just don't know that to be the case.